All right, good evening, everybody, and welcome to this third episode of the IJC. The aims of the Journal Club really are to, one, to refine your knowledge of cataract and refractive surgery and the latest evidence, and number two, to refine your knowledge of research methods, because as ophthalmologists, we'll all be writing papers, and so it's important to know how these studies are designed. So welcome to all of you, and thank you for joining us. My name's Imran Yusuf. I'm an ophthalmology resident and PhD candidate at University of Oxford. And I'm very pleased to introduce my co-host, Basak Bostanci, Associate Professor of Ophthalmology at the Okan University in Istanbul. Now we've got two very distinguished faculty this evening, both from the same institution, obviously very good friends. So we have Professor Wolfgang Mayer, who's Consultant Head of Refractive Surgery at the Ludwig Maximilians University in Munich, and also Medhi Shajari, who's an ex-young ophthalmologist, but still very young, Head of Lens Surgery. At the same institution, also associate professor. So to the two of you, thank you very much indeed for joining us this evening. We look forward to learning from you and your skills in critical appraisal and your experience as ophthalmologists. So,
Imran, do you want to run the poll meanwhile?
Yeah, apologies. Yeah, why don't you run the poll and then I'll try and sort this out on my end.
Can we have the poll questions meanwhile? Okay, so what we want from you is answering these questions in the time we're giving you. So the first question is, in your current clinical practice, do you register detailed preoperative, intraoperative, and postoperative data of all your cataract patients? Yes or no? So 82% said yes. Okay, can we have the second question, please? In your current clinical practice, do you inform patients with those risk factors about the risk of dropped nucleus and needing a secondary intervention before cataract surgery? $76 said yes. Okay, great. The third question, please. This is a tricky one. Do you inform your patients that you're a trainee and the risk of complications might be higher? And if you're not a trainee, please answer in relation to your clinic. Okay, 70% said no. That was expected. And the last question, please. In your opinion, which of these cataract surgery techniques has the least risk of dropped nucleus? Femtocataract, extracapsular cataract extraction, or phacoemulsification? Femto, interesting. Okay, I think we are ready, Imran.
Yeah, thank you very much for that.
Yeah, we have all our questions, so the word is yours.
Okay, lovely. There we go. Thank you. So what I'm going to do is just to, by way of background, just because I couldn't present these slides before, is just to say that you can post questions through the Q&A at any time. So we encourage you to ask questions, and we'll try and ask as many of those to our faculty as we go along. So just to say that. Now, in terms of the, there we go. Hopefully you can see that slide. So yeah, just to summarize the paper really. So this was a paper looking at the risk factors for dropped nucleus from the EuroQuo registry, which is a European-wide registry whereby any individual clinic or surgeon can upload data relating to cataract and refractive procedures, looking at the preoperative factors, intraoperative factors, and postoperative outcomes. And it sort of feeds back that result so that the individual clinic can look at their sort of data and how they're doing over time. So it's quite useful, not just for research purposes, but also for individual clinics to audit their results. So this particular paper looks at the data from the EuroQuo database. So this table, table 1, essentially shows on a year-by-year basis what the frequency of dropped nucleus is for each of the given years for those particular procedures or cataract extractions which were reported in that year. So you can see in 2008, for example, 93,000 cases reported, 87 cases of dropped nucleus within that number, and they then report a frequency, which is just a percentage. And what they say in the paper is that over time, they feel with this particular data that the frequency of dropped nucleus is reducing over time. They don't represent this graphically, but just by virtue of this table, you could probably just about agree with that. Table 2 reports the different procedures which were reported within this cohort. So although you can see that at the bottom, 4,000 cases did not specify what type of surgery was being undertaken, you can see that most of them do. So phaco, of course, is overwhelmingly the most common procedure. And of course, you'd expect, because of that, they would have more dropped nucleus within that group, and you can see that's also the case. They also compare cataract, extracapsular cataract extraction. They compare phaco plus filtering procedure, which can be, assume, any filtering procedure, and also femtosecond laser-assisted cataract extraction. And you can see in the final column there, they give frequency in brackets, which is the proportion of dropped nuclei within that particular type of cataract operation. And I'll comment on it because, of course, they do comment on it themselves in the conclusion. They do mention the fact that the phaco and filtering group has a higher percentage of dropped nucleus. But and this paper is very good at explaining about confounding factors in these sorts of retrospective studies, because you can assume also that if you've had a phaco and filtering procedure, and by definition you've got glaucoma, you're probably more likely to have pseudoexfoliation than the other groups. You're probably likely to be older. And so this very nicely explains or illustrates the significance of confounding factors when trying to interpret data. So don't be fooled into thinking that you can automatically assume that filtering procedure equals a high risk of lens drop just because of the procedure. You must also account for the fact that different characteristics of patients go into those different types of surgeries. So initially what they did was a univariate analysis, and that's when you essentially monitor a single factor or variable in your analysis. So it's useful for giving you an initial idea or initial picture of your data. And you can see that in the univariate analysis, the kind of risk factors that we might expect do come up. So in the second column there, you can see the essential weighting given to that particular variable or risk factor in this case. In the second column, you can see standard error, which is obviously about the spread of the data. They specify a p-value for their analysis, their regression analysis, to tell you that that particular risk factor is significant. In this case, they all are, given particularly the high N number in the study. And you can also see the confidence intervals that they've provided there. We'd assume they'd all be above 1 because all the risk factors are significant. But it's very interesting, I think, as a student of looking at papers, this is very useful to compare the univariate analysis with the multivariate analysis. And as many of you may know, multivariate analysis takes at least 2 different risk factors into consideration, because you might, for example, have 2 risk factors which vary together. For example, pseudoexfoliation and glaucoma are clearly linked, as are glaucoma and age, and so on. So it's very useful then to be able to do a multivariate analysis in order to really isolate a particular risk factor and examine its significance. So here's the multivariate analysis. And you can see that many of the risk factors that were significant in the univariate analysis are also significant in the multivariate analysis. So you can see still white cataract and previous vitrectomy are still the 2 most influential risk factors for dropped nucleus when the multivariate analysis is done. But you'll also see there are some factors on there which weren't there in the previous table. For example, glaucoma was an individual risk factor significant on the univariate analysis, which was no longer significant on the multivariate analysis. So that's an important thing to consider when looking at these sorts of studies. You can see the weighting given to the risk factor in the second column. And you can see there's a negative weighting given to the year of surgery, because the study found that as time went on, that the incidence, or the frequency, I should say, of dropped nucleus went down. And the other values really are similar to, in their nature, to the previous table, so I won't go over those, but you can see you can see all these factors are significant on multivariate analysis. And the large numbers in the dataset obviously allow them to do this sort of statistical modeling. I find this table quite useful. This compares risk factors on the left, and within that particular group of risk factors, how many had a drop nucleus and how many didn't have a drop nucleus. And that's quite useful to be able to sort of think about the values that are given. And also the significance of this table is looking at postoperative outcomes. You can see that the logMAR, mean post-op visual acuity in logMAR is given in the fourth column. The number of cases with a post-op refraction in the next column, and very usefully, the proportion of individuals who attained within 0.5 diopters of their prediction, their preoperative prediction in the different groups. So particularly looking at that final column, I think what you would expect is that if you didn't have a drop nucleus, the likelihood is your refractive error would probably be lower. So that's probably what you would assume. And you can see that in each of those rows, when there's no drop nucleus, that particular group had a greater percentage that fell within 0.5 diopters of predicted. So that does make sense. And so you can go down and you can compare the different groups. And another thing which made sense to me is that if you have a white cataract, generally your risk of your percentage is lower, because clearly those patients may have needed A scans for their biometry, and that in itself can create an error. So when I look at that table, that really is what I was expecting to see. The pseudo exfoliation group had quite a high rate of falling within the 0.5 diopters of predicted. So we can talk about that with our faculty. And I think the final table is quite interesting. So what they do is they group visual outcomes into 5 groups, where group 1 are patients with very good visual acuity between minus 0.2 and 0 logMAR. Group 2, you'll see there's a typing error there in the table. Group 2 obviously means between logMAR 0 and logMAR 0.2. And so on, so with reducing visual acuity. And I suppose what they wanted to show in this table is what proportion of people sort of see worse afterwards in the drop nucleus group compared to before the operation. And so this is quite useful for showing, for example, that for those patients in group 1 who saw very well pre-op, obviously post-op, a lot of them saw a bit worse than that, although there's not many in that group. And conversely, in group 5, where the preoperative visual acuity was quite poor, meaning logMAR 0.6 or worse, you can see that in the end, only 25% of those patients saw about in the same visual acuity group afterwards, and that many of them got better. And of course, this is because there's a floor effect, of course, of visual acuity. So anyway, that's quite useful to know in general about what the type of outcome you might expect is for those particular groups. So just in summary, I'll repeat this box. This is where the authors suggest what was known before. And of course, we knew before that previous vitrectomy, inexperienced surgeons are risk factors for drop nucleus. And what they felt they've added is that they feel as though with this data set, they were more certain about what the risk factors for drop nucleus were, such as white cataract, small pupil, type A retinopathy, PXE, poor preoperative visual acuity, and of course, they've shown that the visual and refractive outcomes are poorer than for uncomplicated cases. So in summary, that's what the paper showed. So I'll try and stop my screen share now. Okay. All right, so I'll hand over to Basak to start grilling our faculty.
Thank you, Imran. So as you stated, we have an outstanding panel today who are very good researchers. So I would like to start by doing the critique of the paper and then discuss the relevance of the paper on clinical practice. So I would like to start with Wolfgang. May I ask you, in their study, the authors stated that they included cases with either a complete nucleus drop or large nucleus pieces that have dropped, but not small fragments. I believe in a multi-center study like this, the authors must be more brief about what the size or proportion of the nucleus must be in order to be included. There is no comment about it in the study. And also, are these the cases which needed vitrectomy? And may I ask you, if you were the one to conduct this study, would you only include cases which needed a secondary intervention? And also in your practice, how small a drop nucleus should be in order to only just follow up and do not do vitrectomy? A lot of questions at the same time, sorry.
Two very, very important questions here. To the first question, what is really important is that's always the lack of such evaluation, of such database evaluation to a high amount of study population. The problem is, in a multi-center setting, if you decide to study different parameters, prospective, you can really get a conclusion about which parameter is studied. So the study protocol will show us, okay, which parameter of this surgery technique, which parameter of this diagnostic parameter or everything else can be analyzed. The problem of evaluating retrospective a huge database like the ERICO registry, you always have the problem, who is putting the data inside, who is defining the parameters, and of course, that's always the tricky part in the database, setting up a database to conclude what parameters are necessary for this type of research, this type of study evaluation. For this paper, it is mandatory that all data should be critically assessed by the database when you look at it to see, is the database full of each parameter. So in case of drop nucleus, you have to think of the parameter drop nucleus. When does the nucleus really get dropped during surgery? The complete nucleus or part of them, part of the nucleus? You have to decide in which time and what is necessary for the patient and the patient's outcome. Yeah. To evaluate just the data of drop nucleus, you see that's a rare complication. It just tells us in a huge amount of study population that the drop nucleus situation is really rare, and we cannot be afraid of posterior capsule rupture to have an occurrence like drop nucleus. That's the main part or the main outcome of this paper. But the problem I see is to define, as you mentioned, to define which kind of drop nucleus is the critical part. So is the whole nucleus dropped, a piece of the nucleus dropped? That's the thing we have to not discuss in this paper, but to discuss in how to access a database like the ERICO registry. But I think that's not really necessary for outcome of complication management for the patient. So what the paper tells us that the drop nucleus situation is really rare, and we have to handle this to take into account with the patient to set up again another surgery to rescue the nucleus and to make a secondary lens implantation. That's the clinical part. For the research part, we have to look which kind of other complications go along with the drop nucleus. So that's not part of this paper, but we have to think about it. And that's the main question always we have in research, in the discussion field, to see, okay, are all parameters really assessed? Are they studied well? How are the parameters analyzed? And to see what is the clinical outcome for the patient and for the surgeons.
And what do you do in your clinical practice? Do you just send all the dropped cases to vitrectomy, or if it's a very small fragment, let's say less than 1/12, you just leave it?
Okay.
Just follow up.
In term, it's a part of the nucleus. You know, there's always the risk of inflammation of the vitreous, of the retina, of the, getting macular edema. So that's very important to handle this in an early setting to rescue the nucleus by doing vitrectomy. When the inflammation is high, you have to control the inflammation first and do the vitrectomy in another surgical step later on. If there's some small pieces of cortex rest inside the vitreous, you think if it's really small, you can just wait. We wait and see how the inflammation will react on the patient, and to see if there's any change over the first surgical post-op time. If there is no inflammation, we wait another time to see if the cortex will diminish by itself. So that's the part just for the cortex. But in terms of nuclei, drop nuclei, you always have to think about vitrectomy first.
Thank you.
I think there is one more thing, if I'm allowed to add, because we are talking a lot about the size, but actually it's also about the characteristics of the cataract itself. So if it's of course very mature and very hard, we have to get into the eye on an earlier stage than if it's on a very early stage of the cataract, right? Like, I mean, it will probably dissolve on its own. I mean, Wolfgang has just like a very tough case. I think it was last week, Wolfgang, if I'm correct, where we had got like this disabled person who then had got like very hot, small fragments of his own lens. It was like he just punched on his own eye, and there were extremely high fragments of the lens inside the eye, and they were small, but you had to get them out, correct? Because they were just like so hard, you knew they would never dissolve.
Of course, because that's the risk also for the retinal detachment if they stay in the eye. That's in good opinion, but what I want to say in addition is that if you have the situation of a dropped nucleus, you have to be aware to inform the patient to see, okay, we have a problem now, and to handle the situation of getting further with the surgery in another step or another day. The other thing is also what this research shows in this paper is that the informed consent has to be also a mandatory part of the surgical procedure pre-op, so that you always have to inform the patient very clear about all the complications that can occur, even the rare ones. And that's good in terms of quality control. This actually for me is the outcome of this paper, that we all should be aware of collecting data more precisely to see, okay, how can we change our own surgical settings, our environment in the clinics or in the outpatient department to have an own quality control system to see, okay, is everything going fine? Do we control every parameter pre-op, during the surgery and post-op to handle such rare complications like dropped nucleus?
Okay, great, thank you. Thank you for your answers. So I would like to go with my second question, and it's for Medhi. In the meta section, the author said clinics decided whether they will report complete data or only pre-operative and surgical data before joining the database. Do you think this will create some bias, especially when conducting a study about complicated cases?
Absolutely, for sure, Basak. I mean, like, this is clear, and this is like the issue, because like on the one side, you want to encourage the people to share the data. So you want to make it to them as easy as possible. And of course, people will share more data, the less information they have to put in, right? So this goes with it. But on the downside of this is, of course, that there will be a lot of data missing. And this is actually like the issue, correct? So when there are actually like the tough cases, when there are things are going wrong, probably the follow-up is missing. Yeah? And this is also something what actually the authors themselves said when you look on the last page of the paper. They said there was like an association between pseudoexfoliation and the dropped nucleus. But they think you have to be very cautious with this reporting because probably it was underrated. And I think this says everything, right? So that there are like just people, or there are physicians who will not report everything, who will not type in everything what is needed to have got like a clean study. And this is the downside with this kind of huge big data analysis kind of studies. On the other side, we have to also appreciate that this kind of studies exist because they still tell us a lot. They still give us at least like a hint where we are heading, what is approximately the case, the complication rate, so that we know what we are facing.
Yeah, thank you. So, Wolfgang, I'm going to ask you a question. In the method section, the author said they accepted a case as a small pupil case only when enlargement of the pupil was achieved using a mechanical stretching device. But we don't use expansion devices in every small pupil cases, which makes the case even more risky. Maybe they wouldn't have a drop if we are using if we would use a stretching device. So I believe the risk with small pupils might be even higher. So in order to state small pupil in a numerical expression, would have been more objective in case, like in studies like this? What do you think about this?
Well, you're right, and that's one part of surgery to see always the patients from the whole part, from corneal, from the corneal situation, from the iris situation, from the pupil stretching situation when you dilate the pupil. That's a problem. Small pupils are always a common problem in pseudoexfoliation, also in hard cataracts. Even also in femtocataract assisted surgeries, we always see some kind of meiosis reaction, which will harden the surgical procedure. The problem I see is always also for research, how really experienced is the surgeon in handle the situation. So is he also in use of handling stretching devices like the Malugin ring or other devices? How experienced is he in doing the capsulorhexis by mature white cataracts? So is he using a staining system or a staining device for the rhexis or not? I always see that also for the trainees, that when they start with complex cases, they always focus in on thinking about what is the next step. That's always the problem if you have to think of the situation not on the whole eye, but what are you doing now? So if you're staining the rhexis, if you're staining the capsule, performing the rhexis, you might be thinking of Argentinian flag sign. You might be not seeing always the rhexis because of no fundus red reflex or because of the small pupil situation. And that's a really thing that you have to be aware about when you start a surgery in complex cases. For the paper, if you study small pupils, you have to think also, as we talked about the nucleus, what is defined as a small pupil? Is it a pupil that will not react on medication, so in dilatating medication, or is it only a small pupil when you're not able to stretch it, or just stretch it with a stretching device? That's the question. And I think for the experienced surgeon, he always has to think about, okay, is there something further than only the small pupil? Is there some inflammation to the eye that I have to handle? Is there a situation like a traumatic situation where the iris is stuck to the capsule? So that's the problem. You always don't see that in the parameters of a database or a registry, because they want to simple up the setting to see, okay, we are looking for a huge amount of patients with some important parameters, but not so much in detail, because it's very hard to analyze this on a really way where a lot of people are involved to set up a multi-center study. So for the huge European database like the Recruit database, it is important just to collect the main parts of the surgical steps for evaluating different complications like endophthalmitis, rare diseases like rare complications like dropped nucleus. That's the way you can only get about out of a huge amount of study people that are involved to the database. Yeah. In a small amount, it's not able to find really a significant change of drop nucleus in a complicated surgery. So that's the problem we always have in setting up a small national or in-house, one-house data evaluation. That's the advantage of a database like the RICO registry.
Well, actually, this is related to my next question. So, Medhi, I know that you have lots of publications. So, as a researcher, I want to ask you, in a study like this, which presents the risk factors of a dropped nucleus, I would have liked to see results about axial length, anterior chamber depth, intraocular pressure, history of trauma, intravitreal injections. So, I want to ask you, how would you change this article's outcome measures? How would you conduct this study in the first place?
Of course,
Like,
for my part, just a comment. That's always the main problem of the big data assessment. That who is getting in the data, what is the parameter looking like, and that's like the whole question of the big data analysis. If you get rubbish in, you always get rubbish out. You have to see setting up a clear structural database for implementing the main facts for your research you want to look for. If you are collecting a lot of parameters which are not necessary for this type of evaluation, you maybe can get mislinked with your statistical analysis because you're looking for such for other things like not complications but prolonged surgical time, which is not necessary for this study we have shown here.
Maybe?
yeah, I mean, like, you know how much I love hard facts. Yeah, so, and this is what I think like would be really helpful to have got like actual numbers we can work with. Yeah, the issue is when we are talking, for example, is a surgeon experienced, yes or no? What does this mean? What is an experienced surgeon? Is it someone who did more than 2 years? Is it someone who did more than 2,000 cases? Where is like the bottom line? Where is the border? Okay, so this is just like nominal data. So it's very difficult to do like a proper analysis with this. But what you just suggested yourself is exactly what we need. We need like hard data. We need like actual numbers, things like what was the axial length of this patient? What was the interior chamber depth of this patient? What was the lens thickness? This is like hard data where we have got like actual numbers and we can do proper statistical analysis with. And I think that would be very helpful. On the other side, of course, I understand that it would be like extremely painful for the person who has to enter the data into the system to go such a long way to find out like every single axial length of each patient and just type it in. So I can understand that that our data house doesn't have got all these numbers, but this is what, if you ask me for my wish, this would be my wish, to have got like hard fact numbers.
Okay, great. Actually, I have more questions, but I would like to hand the word to Imran because I know that he has more questions.
Yeah, that was all really interesting. So I think I'll start with a question about the reporting. So obviously, in this sort of study, the way that the way that the data is reported and who it's reported by is obviously very key, and there's obviously a bias there. So with EuroQuo, is the reporting anonymized? I don't know whether a question to either of you, because perhaps one of you might know.
It actually says in the paper that it is anonymized.
Anonymized, yeah. Okay, so at least that's one thing. So because obviously, if it's not anonymized, people will be a little bit hesitant to report complications. A second thing I wanted to touch on was, I think Basak touched on it partly already, is about the main risk factors that come out on the multivariate analysis in their study. So just for everyone's benefit, I'll repeat what they were. So white cataract, previous vitrectomy, preoperative visual acuity, small pupil, PXE, diabetic retinopathy, sex, and inversely the year of surgery, which was associated with the reduced risk. So, and I agree with Basak, there were some things on there that I was expecting to see which weren't there, like trauma and intravitreal injections, but obviously they may not have looked for those, or they may not have been inputted onto the study. So my question to all of you is, for those risk factors that are there, did you expect them to be there? And I suppose as a second question, is the mechanism of those particular risk factors obvious to you for all of those cases? For example, for diabetic retinopathy. So Wolfgang, should we start with you?
Yeah.
So were there any surprises on that list for you?
Actually, from the list, I think again, it's what I find really interesting is to get you're getting informed about the situation where you can have a drop nucleus situation. So you know that's a really rare complication, hopefully a rare complication, but it shows that different parameters or different situations, hard situations like small pupil, soil exfoliation, combination of that and previous vitrectomy, that are all risk factors for really hard complication. And the drop nucleus situation is a really emergency situation because of the risk of endophthalmitis, the risk of really high inflammation, and the bad thing of a poor visual outcome. You've seen this in the study for the patient.
Yes, okay. And as a second question, just because one of our members of our audience has asked, what do you think the mechanism is behind the increased risk of drop nucleus in patients with diabetic retinopathy?
Actually, I think you know the scenario in the eye because of diabetic retinopathy. You have another inflammatory situation in the eye. The problem is also a diabetic cataract is not a normal cataract. You have a changed fluidic situation in the eye, in the anterior chamber, also in the vitreous. You have more kind of changes in the vitreous from the base membrane, so the anterior border membrane of the vitreous may be too sticky or too attached to the posterior capsule, so the risk for posterior capsule rupture is increased. The other situation to handle a diabetic cataract patient is also difficult on that part because of the Rexis situation. You know, the sonulars are kind of more weak in a diabetic retinopathy situation than in a normal situation. So you have to be aware that the Rexis will get loose when you make it in the too wide or maybe too small with an extension to the periphery. The other situation is if the patient is planned also for vitrectomy or has vitrectomy before, that's also the situation we've discussed with this paper.
Yeah, absolutely. Yeah, no, I appreciate all those points, and it's also important for trainees to be aware of all those things that aren't well known about diabetic eyes. And one thought I had myself was, of course, that in diabetic, the group as a whole, some of those may well have received intravitreal injections as well. So perhaps that might be a reason why too. Medhi, why do you think male sex is a risk factor for drop nucleus, or at least why do you think it's come out in the study as being so?
Yeah, because we are more hard to handle, right? I mean, like, what could you answer on this question? I really don't know. I mean, like, for me, to be honest, like when I first looked on the data, diabetic retinopathy was something I didn't expect, but now that we are talking about it, I think like more and more things come obvious. Male sex, I don't know, like maybe we are less healthy in general, yeah, and this has got like that we are more diabetic or something like this, and all of this is like connected to each other. But other than that, I don't know like why male sex would cause like more drop nucleus. Maybe as a surgeon, you are more gentle when you know there is like a female patient. You are like not hesitating.
So the man of hard facts can't put it down. What about Wolfgang? What about you? Do you have any thoughts on that?
No, actually, nothing to add.
Yeah. All right. What about anesthetic technique as a potential risk factor? Obviously, this study didn't look at that. Do you think it's worth looking at that? Or do you think it will reflect our own biases? In other words, like what Medhi said, that if you've got a patient a little bit more anxious, or maybe you're more likely to give a particular anesthetic technique to a particular group of patients because you anticipate that it might be more difficult. What do you think about looking at that as a risk factor?
Well, actually, that's a good question. I think that's a main part. You have to look for your own study to see, okay, how will this react in a normal situation compared in a risk situation. But I think that you just have to evaluate a small amount of parameters as a complication, like pseudoexfoliation with small pupils, and to compare how they will react in the situation when the patient is anxious or the anesthesia is not doing well during surgery. But in terms of this study we have seen here, I think that is an additional parameter that will not, I think, give an exact outcome in the situation of dropped nucleus to see, okay, which hard parameter like other risk factors like the patient's disease, like pseudoexfoliation or diabetic retinopathy, will prevent or prolong the situation for dropped nucleus.
Okay, well, thank you. Medhi, just one question I'll ask to you from our audience. They say that in a question is that in vitrectomized eyes, silicone-filled eyes have a greater chance of a dropped nucleus. And obviously this wasn't really mentioned in the study. What are your thoughts on that? Do you think that's something that they could look at, or do you think maybe they wouldn't find anything definite about that?
I mean, like, it's just speculation, right? I mean, like, this is like such a raw case, like, of a dropped nucleus, and then having got the patient who has got like a dropped nucleus in the situation of having got like a silicone oil filled eye. Like, usually I would expect that the patient who has got like so many surgeries, probably they already did, like, before they filled up the eye with oil, they already like did him pseudophakic. So I think it's a very, very rare case where we have got this. And I think this would be like total speculation that you would have got like still the lens and like an oil-filled eye on the other side.
Yeah, okay, that's fair enough. Yeah, I mean, I think silicone oil in the eye, there'll be many different situations, and there'll be a very complex group in itself.
Exactly.
So maybe that'll be difficult.
The better question should be what are the further complications with dropped nucleus? So it's not about of the rescue again of the nucleus and to implant an intraocular lens, but to see, okay, if you don't handle this over time or in an early time period, what can the dropped nucleus made to the patients in terms of inflammation or something else.
Yeah, absolutely. I suppose that brings us on to another part of the discussion, which is about the post-operative outcomes. Because of course, this study only looked at outcomes up to about 60 days. I think they said in the paper anywhere between 7 and 60 days. And so that obviously brings into question the factors that you mentioned, Wolfgang, about long-term outcome. But just in terms of post-operative outcome, in general, you can see from table 5 that generally those who had a dropped nucleus had less, a lower likelihood of getting within 0.5 diopters of predicted. Why do you think that is, Medhi? Just for the benefit of everyone listening, why is there a greater risk of a poor refractive outcome after a dropped nucleus?
Yeah, of course. So how does it work with our calculation formula? So like we usually go by implanting the lens into the capsular bag. Okay, so this is like our target in cataract surgery. And for this situation, we have got like a huge database. Yeah, so there's like the Hill formula, there's the Kane formula. So we know like many situations when we have got like the actual situation that we can implant the lens into the capsular bag, that we will get a good likelihood because of the big database. On the other side, if we have got like a dropped nucleus, so where do we implant the lens? Yeah, I cannot put it most likely anymore into the capsular bag. So I have to put it like either in the sulcus or do even like a secondary fixation, like Yamano technique, or do an artisan fixation, like basically iris fixated lens on the iris. And for this situation, our database is much smaller. Yeah, so our calculations are much worse. And due to this, it is natural that we have got like a worse outcome in terms of the prediction as compared to the situation when we place the lens into the capsular bag.
Yeah, okay. And that brings me to my next question about...
okay, you're going to ask the same question, I bet.
Just a question about whether the IOL was implanted as a primary or a secondary procedure, because of course, for the reasons you mentioned, Medhi, that can affect the outcome. I know there's one unit, at least one unit in the UK, where if there's been a posterior capsular rupture, because it's a training unit, their policy is to leave that patient aphakic every time and then bring them back for a secondary IOL procedure. I think the reason for that in their unit is they feel as it's more controlled, exactly, it's a planned procedure, exactly what you're going to implant. And I think generally after a PC rupture, people's clarity of thinking can sometimes fall, particularly trainee surgeons. And so that's kind of what they've decided to do to improve outcomes in their unit. So obviously it does make a difference. And it's something that this study doesn't really talk about, whether in this particular drop nuclear group, whether the IOL was implanted as a primary or a secondary procedure. Wolfgang, what do you think that might limit in terms of our what we can see from the post-operative data there in terms of visual outcome and refractive outcome? How do you think that might be limited by not knowing that particular piece of information?
Of course, that's I think that's a main limitation when you don't know this fact of secondary implantation of an intraocular lens. I think the situation for just leaving the patient aphakic is always necessary when you have real heart complication with high inflammation, corneal swelling, and if you not can handle this secondary implantation in the same procedure, even if you're not experienced enough. But for the research, of course, it's very necessary to see, as we talked into the beginning, to set up really clear all parameters for such a kind of evaluation. I think it is well done for the situation of a rare complication like drop nucleus to see for some other risk factors which can influence this situation. But as you really clearly state here, that there are a lot of other parameters. Again, the situation of leaving a patient aphakic or not over the course of the study evaluation period, that is very useful to evaluate all of these parameters in a really, really good structured database. But as Medhi told us, it's very, very hard to put all this data together. I think what we think for the future is that to be aware of more control settings in our clinics, in our environments where we plan surgeries, perform surgeries, to see, okay, how our own quality control systems to set up all data, to collect data, and to have the patients in the right and good way for performing cataract surgery, because in the end, always the patients counts for a good visual acuity, and that's mandatory for every kind of surgery and also for research.
Okay. I suppose one of the cautions in the case of a drop nucleus is that the vitreoretinal surgeon, if it requires a second procedure, might use heavy liquids to float up the lens fragment. And of course, if that's a possibility, then you putting a lens in or primary IOL implantation may be less attractive at the time. So anyway, it's just one point to make. And I think that there was a question about that from our audience as well, about exactly that. What would you do at the time of drop nucleus? Would you do a sulcus, an AC IOL, or leave the patient aphakic? And I think we've covered a lot of those and the advantages of those particular combinations of treatment.
Control the situation. So if it's always a good thing if to leave the patients aphakic, to handle inflammation, to get control of the situation, and to plan the secondary implantation a little bit further afterwards to get control also of the biometry assessment to get most out of the situation.
Okay. Basak, I'll hand over to you if you've got any questions or questions from the audience.
I think most of the questions from the audience is answered, and we have to move to the slides of yours.
Okay.
To summarize.
All right, let's hope I can do this.
Actually, do we want to do a final poll before you start? Oh, you just, okay, go on.
We can do a poll over the top, yeah.
Okay. Okay, we have 2 questions only. We are asking our participants, do you think that patients should be told a numerical likelihood of dropped nucleus during cataract surgery? For example, 50 times higher if white cataract and previous vitrectomy. Okay, I think very close. Okay, can we have the second question, please? Do you think that patients should be told that a trainee will be performing their surgery and the risk of complication is higher because of this? I'm very curious about this, what our participants would think about this.
Remember, your responses are completely anonymous.
Yeah. Okay, I think very close again.
It has gone down. It has gone down a bit. It was 76% before, now only 58%.
Because now that we learned that the risk is higher, so.
No, but that was the question whether they tell it, right?
Yeah.
And now it's a question whether they should do it. So, it's
a very important question, because even in the UK, there's a discussion, I don't know whether it's the same in Germany, about how open we should be about telling patients about their increased risk of trainee performed surgery. We tell them about the other risks. And actually, trainee performed surgery is more important because it's a modifiable risk factor. You know, if you've got a white cataract, you can't really change that, but you can change who your surgeon is.
Okay, let me ask you a question, and I'm asking all 3 of you. In your countries, do you tell the patients that a trainee will be performing there? Or do you just tell them generally they will be under supervision and it might be a trainee or not? In my country, it's, you know, like they don't know if a trainee will be performing surgeries. They know that there's a possibility of a trainee can do their surgeries.
The same situation at our clinic. I just can talk it from our clinical side, but not for the country. But I think it's also in Germany that you not really tell the patient that the trainee will perform the surgery, but maybe in kind of a supervision, and that someone is looking at, okay, and we're doing the surgery together. And that's the main part. You can, or a situation that you can discuss with the patient. Yes.
Yeah,
and I think that's very important what Wolfgang said, right? I mean, like, it's a bit difficult to really admit that a trainee is doing it, but what I think is helpful for the patient, or it's like they are not surprised if you tell them in advance, I'm doing this procedure together with a colleague, so that they know if there is like some switching, or if there is some talking or something like this, they are not surprised, yeah? And they expect that. So I think that's very important what Wolfgang said.
Yeah, absolutely. I mean, I just talk for the UK. Mostly it might vary between departments, but in general, on the National Health Service, because it's a publicly funded service, the general rule is that your surgery is going to be performed by somebody competent to do it, but you can't name who that person will be. And so I think the assumption there would be the same, that we wouldn't tell them necessarily we were a trainee. We do say that we're a registrar, which by definition means we are a trainee. So that is implicit, but most patients who come won't know what a registrar is. So there's that too. And of course, we're supervised too. I completely agree with what Medhi said, that it's good to tell them what will happen during the surgery. That gives them some comfort knowing that this is to be expected. But now, obviously, with what I said before, that there's now this increasing level, so threshold for consent in the UK, which is you have to tell a patient about their material risks, what a patient would find a material risk rather than what the doctor would. So there's been a very crucial change in the threshold for informed consent. It used to previously be what the doctor considered an important risk factor or an important thing to tell the patient, whereas now it's a patient-centered thing. So now it becomes important to tell patients about who's doing the surgery and what the level of experience is. Some patients obviously do say, you know, how many of these have you done? Occasionally a patient will say that, and you have to obviously be honest about that. But it's not routine that we would tell patients that we are a trainee, we've done less than another surgeon in the unit. we don't, that's not mandatory for us to say that, but I think the views are changing slowly. So I think it will change in the future. But just an interesting point. All right, if there are no more comments, I'd just like to thank our faculty and thank our audience. So Wolfgang and Medhi, it's been a real pleasure having you on with us this evening, and we really do appreciate all the insights you've provided for us and your academic backgrounds in dissecting this paper, and I think it's been of great benefit for all our audience. So thank you very much indeed for your time.
Thanks for the invitation.
Oh yeah, you'll probably get another one in due course, Medhi. And so Wolfgang and Medhi, you'll notice those names are on the paper. So this is where we got them in for this paper, so that we can feedback very honestly about this paper. It's a very important one. It's a systematic review / meta-analysis of femtolaser assisted cataract surgery and conventional cataract surgery. So do be aware of the date. Save the date, 23rd of September. It's a very interesting paper and one very relevant for all of you. So do join us for that. And I'd like to thank Basak, of course, my co-presenter too.
Thank you so much, and thank you for our panel. It was really nice being with you, and we will see you next time.
Thank you very much.
Thank you.
Thanks, guys. Thanks a lot.